Yes, this is the second trial. I don't know why I failed on the first trial. Anyhow, today's lecture is about the odontogenic and the non-odontogenic pain, which means that it's the pain from the source, if it is a tooth or the periodontal ligament, something related to dentist work, or the pain in the oral facial area where the source is not. So we will start with definition for the pain. Then we will talk generally how the pain is transmitted and how it will be interpreted on the patient behavior. Then we will talk a little about the dental pain. Next lecture will be about the pain in the orofacial area, where the pain is not related to dental work. So really the pain is the unpleasant sensory and emotional experience. Mostly is associated with tissue damage, okay, or something described as a tissue damage. Okay, damage could be chemical, could be mechanical, could be anything. The causes of a human suffering. It causes a human suffering and it affects its social life and even its economic life because it's affected works. He cannot work perfectly. Anyhow, pain have the advantage for us as a dentist. If there is no pain, no one will ask about our service. So pain is a motivator that provoke individuals to, even though it's well-known fact that the toothache is the most common pain in the orofacial region. But reality, there are some other areas where the pain is predicted in the oral. So to understand pain, we have to make some review for the neuroanatomy, which means that the structure of the orofacial region can be divided either to somatic or a neural structure. The somatic structure it related to the organs, related skin, for example. So the somatic structure that make up the different and non-neural tissue or organ can be further anatomically divided into superficial and deep. The superficial could be the skin, the mucosa, the gingiva. Okay, so the pain arises from the superficial structures, usually always localized. For example, when you explore with a sharp explorer or the pocket measuring probe, you are measuring a pocket in the gingiva. Patient can tell you the pain and he can feel it localizedly. He can tell you you have measured this. Okay. While for the deep structure, like the musculoskeletal and the visceral tissue, pain is purely localized and diffuse. For the neural structure and the perception of pain include afferent fibers and efferent fibers. Afferent that takes the signal toward the brain, mostly are sensory, and the efferent that bring the signal from the brain to the human body to regulate the somatic structure. The nerve impulse are transmitted from the oral facial structure to the brain, okay, via the peripheral nervous system, where the modulation and interpretation of this impulse into what we feel as a pain, everything occurs in the central nervous system. So we have the site of the pain, which is the source, the site of the trauma. We have the nerves that are the transmitters, and we have the brain that receives the signal and again modulates it and gives us another signal. Yes, this picture can show you the relation, and you can see that the pain is transmitted how to the peripheral nervous system is the pain that arises as a result of any tissue damage or any potential for tissue damage. This will transmit it via terminal nerve fiber. We call them primary efferent nerve fiber. So these efferent nerve fiber, they are nociceptive pain sensing primary efferent fiber, which are present and distributed, okay, to detect any noxious stimuli. Either the alpha delta nerve fibers or the C fibers. Alpha delta nerve fibers are myelinated. Their diameter is different, bigger than the C fibers, which are unmyelinated. Definitely each one transmits certain type of pain. Yes, both fiber types have a wide distribution throughout the skin. The oral, yes, throughout the skin. The oral mucosa and the tooth pulp. Okay, there are also other classes of fiber. They they are also they are meant to detect the non-noxious stimuli such as vibration, proprioception. These are mostly present in the periodontal ligament, skin, oral mucosa. The primary efferent neuron, which means that the first nerve that transmits the pain. Primary efferent neuron, the trigeminal fifth cranial nerve. The nerve detects and encodes the noxious stimuli for the orofacial region. The majority of the cell body of the trigeminal sensory fibers are present in the trigeminal neuralgia. If you remember, it's present at the floor of the middle cranial fossa. If you remember, in the anatomy, this sphenoid bone, it's just there. The peripheral axon of the trigeminal ganglia runs in three divisions, as you can see here. Clear. This is one. Yes, you see, this is the lower mandible. This force transmitting to the brain, and this is the synapses, white matter and the gray matter in the medulla condylus. Okay, and then it will. This is about the dental pain. The rapidly conducting myelinated neurons, as I said, they are very efficient response, have a good response to a light pressure, light signal. Activation of these fibers, normally interpreted by non-painful mechanical stimulation under certain conditions, can be perceived as a pre-pain sensation. And sometimes when you're on diagnosis, okay, just when you press on the do percussion, and so the patient can tell you that there is a feeling of pre-pain. It's the alpha beta fiber which are present in the periodontal ligaments. So the alpha beta fiber, they undergo a phenotypic change that allow them to encode painful stimuli under certain inflammatory conditions. After the peripheral nervous system, we understood the C and the alpha fiber, how they are stimulated by any inflammation, chemical change, any chemical, mechanical, any change can create inflammation. Such an inflammation will evoke the the immune system. The immune system, then the prostaglandin after that will transmit the signal to the nerve ends, and these nerve ends will transmit that signal to the dorsal side of the central nerve of the central nervous system. I mean, to the yes, to the spinal cord, for example, the dorsal side of the spinal cord, and that will be transmitted through synapses to the brain. Okay? So the brain will reflect that through the sensory nerves, and so on. So it's a cycle. So for the central sensitization after peripheral tissue injury, there is an afferent barrage from C fiber resulting from peripheral tissue inflammation. Okay, this will decrease the threshold and spontaneous firing of the afferent fiber. There will be stimulation of these fibers. So that was the first order. The second order, those neurons will receive this prolonged barrier of nociceptive input. The second order neuron becomes sensitized. The result of this referred to central sensitization. Result of central sensitization will enhance the processing, the amplification of this signal. The neural impulse will be transmitted to the brain. Then in the brain we will have a secondary hyperalgia and referred pain. These two effects. Yeah, the fast alpha fiber and the unmyelinated fiber. This is the site of energy. Then it will be transmitted through, and you see the inflammation and the prostaglandin. This will evoke, stimulate the nerve where through synapses to the spinal cord. In the spinal cord, this is the afferent. Then we have the to the dorsal ganglion, you can see, and this will go to the tract up to the brain. Okay, and then regulate that. The secondary hyperalgia we were talking about is an increased response of the painful stimulation at the site of the pain, result in central nervous system change. This, in contrast, if I compare it with the primary hyperalgia, the primary hyperalgia, it is of a lower pain threshold, result from the sensitization of the peripheral neuron. Secondary hyperalgia might be felt in superficial areas like the skin and gingiva. The deep structures could be like the muscle and the teeth. So we have a primary hyperalgia, we have secondary hyperalgia. The secondary hyperalgia could be superficial, deep. About the odontogenic toothache, which is the pain on the orofacial lesion. Okay, we expect the pain to be from the pulp dentine complex or from the preradicular tissue. Both of them have C fibers and alpha beta fibers. Although the mechanism of the pulpal and periodontal lesion, mostly the cause of pain, is inflammatory in origin. Okay, each pain behaves differently, perceived differently. Periodontal pain is well localized due to the presence of the proprioceptive fiber and the periodontal ligaments. Usually the patient, when he comes to you, he can localize the pain. He will point for the tooth, while the pulpal pain is poorly localized. Mostly he will refer the pain to another tooth, but again, either another tooth from the same side or the opposing side, but it never crosses the midline. Like for example, pain in the lower 8 might affect the ear, pain in the upper 6 or 7 especially might affect the sinus, and so. So that pain transmitted from the alpha delta and C fibers As I said, the C fibers are unmyelinated, then the alpha delta are myelinated. So the unmyelinated, they are very slow, okay, very specific in transmit the obnoxious stimuli. They go through the area of the spinal nerve known as dorsal root ganglion. I said all these sensations will be transmitted to the central nervous system via the peripheral nervous system. They will be transmitted to the dorsal root ganglion, and once they reach the central nervous system, they will be multiplied, multiple relay. They will be transmitted through synapses. If you remember, the multiple relay stations are the synapses. They will send the signal to the brain. What really matters for us is the delta fiber, alpha delta fiber, and the C fiber. Most of the fibers, alpha delta fibers, are present in the coronal portion. They are sensitive to air, cold, heat, drooling, cropping. I said they are very sensitive. In the previous slide, we said they are very sensitive. They give you a pain which is fast, sharp, short, well localized. That's why there are a lot of alpha delta fiber in the peridental ligament. That's why the pain is more localized. C fibers, the unmyelinated one, they respond to some inflammatory mediators, mechanical deformation, heat. So the pain will be slow, dull, lingering pain, poorly localized. So the type of pain can give you a clue at what stage or at what level the inflammation is. If it was sharp, then it is a coronal portion. Okay? In dentistry, the most important and the primary concern in the orofacial region, as I said, are the trigeminal nerves with their three divisions: thalamic, maxillary, mandibular, because they innervate most all the orofacial region. We have the ophthalmic, it controls the aperture of the eye. The maxillary, it is sensory and innervate the sinus. And the mandibular branch, and motor parasympathetic. You can see here the same. We have something called heterotopic pain. There is something in dentistry, it's not only in dentistry, but we deal with it a lot. The heterotopic pain is the pain present in an area is completely different than the true source of the pain. It's either a referred pain, when the patient comes to you, tells you that I have a pain in the lower 8 region, while the real problem is in the upper 7, for example. Or somebody tells you, and you will see here it's clear. So we have two types of pain, either a primary pain or secondary pain. Primary pain is when the site at the same the pain at the same site of the trauma. Site and source are the same. Secondary pain, the site of the pain is completely different than the source. Secondary pain could be central, which is something related to the central nervous system, like structure of the nervous system. The problem is with the central nervous system, but peripherally it causes the pain, like somebody having sciatica, for example. The problem is with spinal cord, but he feels the pain in the leg. And there is a lot, but these things are really related to a general medicine, so we don't deal with it a lot. Projected pain. It felt in the peripheral distribution of the same nerve that mediate the primary nociceptive input, which means that sometimes patients come to you telling you that he have some paresthesia or anesthesia in the lower lip or in the chin area. Check for the mandibular branch of the trigeminal. Maybe there is a history of extraction in the lower 8 region. Maybe some damage had happened, maybe a history of a trauma affect the tract at the beginning, and he feels something at the end of the nerve, peripheral distribution of the nerve he will feel it. While the third is the referred pain. It is pain occur in an area which is innervated by different type of nerve. Now that's our lecture for today, and thank you a lot for listening, and hope to see you